Can you have the slides, please? Thanks, Ashraf. First of all, I'm really grateful to Professor Mohan Desai and our team of people who have made this course possible. And I am going to talk to you about hip examination. You know, in MS or in DNB exam, you get hip case as a long case. Either a hip case or a spine case, you will get as a long case. Or rarely you will get a CP case or something like that. Then probably you are unlucky on that day. Otherwise, hip or spine case you will get. So you have to be extremely thorough in hip and spine cases. Of course, in DNB, your long case and short case carries equal marks now. In 50 marks for long case, 50 marks for each short cases also. But in MS examination, a long case carries more importance, and short cases, of course, together they carry the equal amount of marks. So before we proceed, you must read SDAS. Those of you who are not reading SDAS, nowadays I find that many people are not going through SDAS book, they are going through other examination book. Remember, your examiners, whoever is coming, including me, we have all read during our undergraduate or postgraduate days this book. So we want you to present whatever is given in this book, line by line, word by word. Okay, that will save you in your examination. Otherwise, it will not save you if you tell any other quote, any other book. Okay, so examiners are more familiar. So it has given long case to how to proceed in order, and I will go according to this book only. Of course, added by with our experience and other things. So I'll present you from beginning from the history till the end of the examination. If you have any doubts, you can ask 1 or 2 questions, or else we have again 3-4 cases for presentation. So we can discuss during that time. You can ask your questions also. This book I had bought in 1986 when I was an undergraduate student. So it is more than 40 years now. I'm writing my name as a medico, then, of course, as a doctor, then professor, whatever, then it will keep on adding in that book. So still I'm going through that book. And also I read it yesterday again. So every time I read, I get some new points. So read everything from that book. I'm telling you, line by line, word by word. So first thing is that you take a history, of the patient. History is his story. Listen history carefully. Okay, because history will give you 50% diagnosis. From the history, you could guess. Even now in the clinic, if you're seeing the patients, we're seeing the history when the patient enters and takes the history. Okay, his ankylosing spondylitis for sure. Is a case of avascular necrosis. Is a case of fractured neck femur, which is not united. Operated, okay. Might be some failure of the surgery. So like this, you can make a diagnosis and accordingly you can proceed in the examination. What is the age of the onset of the patient? Age of the onset, different ages have got different disease specific that particular age. 0 to 5 years, say developmental dysplasia. 5 to 10 years, Perthes disease. 10 to teenagers, 10 to say 18 years or so, slipped capital epiphysis. 20 to 40 years, some inflammatory arthritis like rheumatoids or anything. 40 to 60 maybe secondary osteoarthritis, or beyond 60 years, it may be primary osteoarthritis of the hip. So these are the common conditions. Remember, in our country, tuberculosis is very common, and tuberculosis can affect any age. So any age patient may present with tuberculosis. That you should keep on the back of the mind. Now, pain, other things, pain, swelling, loss of function, we'll describe a little bit in detail. So pain, whenever you ask about pain, what is the onset? Whether it's acute onset or a gradual onset. Acute onset, usually, the traumatic episode. Gradual onset, some kind of arthritic conditions. Duration, what is the duration of the symptoms? Remember, in the past, if 10 years back, he has a fractured neck femur or something like that, and now presenting with the pain, then you must ask that, how long it's bothering you? Last couple of months, 2 months, 3 months. That you must tell in your chief complaints. Okay, but that past history of fracture, anything that you should tell in the history of past illness, or maybe whatever past history. But if the symptoms are continuing for the last 5 years, from that fracture neck femur, operated, didn't get relief, second surgery, third surgery, underwent something like that. So if that symptoms are continuing, then you tell it's a history of the present illness. You describe that thing, that history of pain for the last 5 years. And now gradually these are the things. Then the character of the pain, of course, sharp pain, dull lacking pain, and radiation you must track. Especially in children in Perthes disease, you will find patient may not complain of the pain around the hip. They will complain pain around the knee. Okay, that is because of the radiating pain to the knee, because of the common nerve supply, like operator nerve. Next, this you must remember, this table is extremely important. What is mechanical type of pain, inflammatory or infective type of mechanical type of pain that gets relieved with the rest and get aggravated with the activity. Whereas inflammatory type of pain, like rheumatoid arthritis, say hemophilic arthritis, all these things, they get aggravated with rest and get relieved with the activity. That's why when the rheumatoid arthritis patient get morning stiffness when they get up in the morning, and once the activity, they resume their activity, the pain gets eased off. That is because of the pain factors or inflammatory factors which are accumulated, they get washed away with the circulation. Next, infective or neoplastic, pain will be present at rest but gets aggravated with activity. That means the pain is continuous. It is there as well as the rest of the activity. So from that, you can get an idea that what kind of condition you are dealing with. Next, swelling. What is the site, size, duration, onset, all these things. The entire chapter on swelling in the S. Das book. You can go through that, and accordingly, you can, suppose there is a swelling, you have to talk everything about the swelling, whether associated with pain, whether progressing. Next, limp. Limp is usually first noticed by the relatives rather than the patient himself. So, patient, or you will, as an examiner, you can, as a doctor, you can notice the limping of the patient rather than patient noticing it. What is the onset, duration, whether pain is there or not? Remember, whenever you are telling about the gait, when you are commenting about lurching gait, remember it's a painful gait. If the patient has no pain while he is walking, then please don't comment it's a lurching gait. Just 2-3 points. Gait is a separate lecture altogether. Trendelenburg, when there is a unilateral affection, unilateral abductor function weakness, due to some reason, unilateral CDH, Coxa-Vara, then it will be a Trendelenburg gait. Whereas waddling gait, when there is a bilateral involvement. Okay, bilateral Trendelenburg gait, you can tell it's a waddling gait. Okay, like bilateral CDH. So waddling gait is when the bilateral influence. So there are couple of points. If you should not, make a mistake on this. Next, past history. Of course, trauma is important. Trauma is almost 50%. You first ask the history about trauma. Whether you have a fall, you had a fracture, you have anything, then entire gamut of 50% of orthopedics is ruled out. Disease aspect ruled out. Only your traumatic aspect remains. Tuberculosis is important in our country, as I told you. In tuberculosis, you ask that whether there is past history of any fever, cough with expectoration, loss of weight, evening rise of temperature, all those things. Remember, in bone and joint tuberculosis, usually you do not find all those things. So do not comment by mistake also that patient has a, loss of appetite, loss of weight. Bone and joint, hardly we find all these generalized symptoms. There may be wasting of the muscles, but all these symptoms usually is found in pulmonary tuberculosis. Skin disorders and drugs taken, usually chronic conditions like skin disorders. Remember asthmatics, and remember any kidney affection. All these people, they take steroids. Okay, so see from that, so you can suspect that the history of intake of steroids. Chronic skin conditions, chronic kidney conditions, and any asthmatic patients. Neurological steroid intake is important, and sometimes in young patients you will find for bodybuilding they may be taking steroids. That also you can ask in young patients who you find little muscular and all, then you ask about history of steroid intake. And nowadays, of course, we are taking a COVID history because many patients, they are affected with COVID, either by COVID or treatment with steroids after the COVID. There are two things which can lead to avascular necrosis. Personal history occupation is important because the examiner will ask you that while you are telling about management of the patient, then examiner, what is the occupation of the patient? So that's why occupation is important. But accordingly, you have to design your treatment. Because suppose hip joint affection, you are going totally arthroplasty, is a daily laborer, he wants to do ground level activities, then totally arthroplasty might not be a good idea to do. You can tell something else. So that is why occupation is important. Diet, smoking and alcohol, how much smoking, how much alcohol, that is important. If you have got a avascular necrosis case, examiner may ask that how much alcohol he is taking, how many years, okay. What is the dose response relationship in alcohol? So that you must keep in background, that must be prepared with those kind of questions. Then postmenopausal history, of course, regarding osteoporosis. Family history, tuberculosis, close contact of the tuberculosis, dysplasias, metabolic storage disorders, and inflammatory arthritis. These are the conditions which may run in families. So you have to take the family history of these kind of conditions when you take a hip case. Next, we come to the examination. Okay. The prerequisites for examination that your patient should be dressed enough to cover the private parts. Patient should be lying on a hard bed or a firm bed at least, and you have a marker pen, you mark the skin and draw all those lines. Examiner would like to see these marks that you have made, brand strangle, you have made, all these markings. But remember, after you finish your examination, wipe out those marks. Okay, many people, many students, they forget because of tension in the examination. There is a spirit which is available, spirit or ether which is there. Wipe out those things. And if there's a female patient, always tell the sister should be there, standing there. Insist on a sister should be, or maybe a female attendant, somebody who should be standing there. Next, we come to important part: inspection, palpation, movements, measurements, special tests, gait, and other system examination. So you examine the patient from the front, attitude and alignment. The important thing is when the patient walks, then you can get many things. You can understand many things, like whether there are any fixed deformities, what are the level of the anterosuperior spine, whether there are the same level of the knees, level of the ankles, whether there is any visible wasting of the adductors or the quadriceps wasting, thigh muscle wasting compared to the opposite side, and whether there is swelling, scar, or sinus which is there, which is obviously appearing that on inspection. And from the behind also, see if there is any scoliosis. Is there any, both the and posterior superior iliac spines are at the same level. Wasting of the glutei and hamstrings may be apparent when you see from behind. Remember, sometimes when the patient has got a flexion deformity of the hip, you see from the behind, you feel like there is wasting of the buttocks or muscles of the extensors of the thigh. But remember, the flexion deformity, it may appear like that, but there may not be any wasting of the buttocks or flattening of the buttocks. From the side, you can know there is a flexion deformity of the knee, flexion deformity of the hip. Is there any scars? Okay, which is there, that what incision has been taken. Sometimes they may ask you that what is this type of incision, what surgery might have been done, what you guess. Okay, so kyphosis, lumbar lordosis, attitude of the hips, knees and ankles you see. Next, in the supine. Supine you see attitude of the hip, knee and ankle. Is there increased lumbar lordosis, and both the anterosuperior iliac spine are at the same level or not, and position of the greater trochanter. Okay, if there's a thin patient, you will appreciate, or it's a little obese patient, then you may not be able to appreciate the position of the greater trochanter or any prominence. From the side, what you see, the Scarpa's triangle, is there any fullness? Sometimes in tuberculosis of the hip, there will be a possibility of cold abscess somewhere. Okay, so Scarpa's triangle, fullness and scars and sinuses, wasting of the thighs and position of the patella. Most important thing what you see from the side is the increased lumbar lordosis. So that will tell you about there is a possibility of flexion deformity of the hip joint. Okay. And the calf also, see the wasting. So grossly you see whether both the knees are the same level, both the medial malleoli are the same level or not, whether the heels are at the same level or not. Next we come to the palpation. Palpation, remember, always you tell the first local rise of temperature, then tenderness. That is the order. Okay, don't just go on telling that all other things. First, there is no local rise of temperature. There is anterior joint line is tender, like that. You should tell it like that. And then any scars or anything. And lymph nodes. Sometimes if the lymph nodes are present, the examiner may tell you that which group of lymph nodes is enlarged. Remember, around the inguinal region, there are two groups, superficial group and deep group. The superficial group is, again, there are three groups: superficial medial, superficial lateral, and there's a inferior superficial. And there's a deep inguinal lymph nodes. And now next the examiner will ask, now hip joint drains into which group of lymph nodes? Anybody? External iliac group. So different books have given different groups of lymph nodes. Remember, answer like this: if the anterior part of the joint drains into deep inguinal lymph nodes, whereas the medial and posterior part, they travel along the obturator vessels to the internal iliac nodes. Okay, like this, you just describe in partly because many books have given only deep inguinal node. Many people are given that. On palpation, confirm the diet. Then you come first local rise of temperature, then tenderness, then confirm the findings on the inspection. Then you tell, I confirm my findings on the inspection. Next important point comes in the inspection in the anterior joint line. Okay, anterior joint line. Remember these two landmarks. The line joining the anterosuperior iliac spine and pubic symphysis is the midpoint of that line is known as mid-inguinal point. Whereas the midpoint of the line joining the anterosuprailiac spine and pubic tubercle is the midpoint of the inguinal ligament. Okay, so this point, lateral point is same, whereas the medial point is different. Since this point remains lateral to this, so midpoint of a inguinal ligament remains lateral to mid-inguinal point. Whenever you tell anterior joint line is tender, it is with relation to mid-inguinal point. So joint line remains about 2 to 3 centimeters below and lateral to the mid-inguinal point. Often the candidate gets confused, so you should be very clear about it. So it is just lateral to the femoral artery. If you palpate the femoral artery, just lateral to the femoral artery. You don't comment about posterior joint line commonly during your routine examination unless the examiner asks you. Okay, so where is the posterior joint line? It is at the junction of the lateral 1/3 and medial 2/3 of the line joining the posterosuperior spine and tip of the greater trochanter. Correct? But because there is a thick muscle, gluteus maximus is there, it is difficult to palpate the posterior joint line, but sometimes some examiner may try to ask you. So just remember this for your knowledge sake. Next, you palpate and mark. So after palpating anterior joint line, then you go gradually laterally. The anterosuperior spine, iliac crest, posterosuperior spine, like that you go in a particular order, then come down to the greater trochanter. So palpate and mark all this iliac crest, posterosuperior spine, whether there is any tenderness, whether there is any thickness of the bones, thickness, irregularity, because that is a possibility of osteomyelitis affecting the ileum also. So level, then greater trochanter you come. What is the level of the tip of the greater trochanter? Whether there is broadening, thickening, then edges, all these things, bitrochanteric pressure, all these things you tell in palpation. Next come if there is any swelling. Of course, I told you whenever there is a swelling, then you describe like a swelling, whatever is given in your SDAS book of the swelling examination. So many times, cold abscesses, they may present somewhere in the medial, they travel along the medial side of femoral vessels. So it may present in the Scarpa's triangle, it may be posteriorly in the gluteal region, or it may go to the acetabulum. Sometimes it trickles down to the medial aspect of the knee until the medial malleolus also. And last thing in the palpation is that a vascular sign of Narath or palpation of the femoral artery. The order is that vein from medial to lateral, vein, artery, and nerve. Okay. So if the femoral pulse is well palpable, then vascular sign of Narath is negative. Okay. If it is not palpable or feeble compared to the opposite side, then vascular sign of Narath is positive. This is another thing where the students get confused during examination. What is positive and what is negative? Next, you come to the movements. So the movements in the hip joint, these are the movements possible. Remember, when the examiner asks you that what are the movements possible in the hip joint, in addition to all the 6 movements, the last you also tell circumduction, because it's a ball and socket joint circumduction. Though you don't comment about circumduction, but if they're asked about what are the movements possible, you tell about the circumduction. In what plane which movements takes place, that is important. Remember, in sagittal plane, flexion and extension. In coronal plane, abduction and adduction, and in vertical transverse plane or transverse plane is the internal rotation and external rotation. And these are the normal amount of movements which are possible. Remember, when you are asked about flexion, tell in the extended knee as well as flexed knee. In extended knee, 90 degree, in a flexed knee, about 120 degree. Okay, this is what is important. And in fixed deformities, your starting point should be point of the fixed deformity. Suppose 30 degree of fixed flexion deformity, then you tell there is a fixed flexion deformity 30 degree, and further painless range of movement is present up to the say 60 degrees, and further movements are painful. Okay, like that. So it will start from 30 degree. Whenever you are describing movements, these points you should keep in the mind, that what are the fixed deformity, what is present, what are the further range of movement possible, and whether these are active or passive movements, and whether painless or painful movements. And while examining the movements or while you are showing the movements, then you see the one word of caution, you have to stabilize the pelvis. You have to stabilize the pelvis and always compare with the normal side. Okay, examiner tells, okay, show the movements. Then first start with the normal side. Then they will tell, okay, then first have normal side. Then you go. But always start with the normal side. Sir, I want to compare with the normal side. Next most important thing is the Thomas test. If you are unable to tell Thomas test properly, then you are likely not to get succeeded in your examination, clinical exam. There are certain points, Thomas test, your true length, apparent length, and your telescoping and Trendelenburg test. These are the important aspects of exams. If you are not able to tell it properly, then there is a problem. Okay, you are inviting problem. So Thomas test, remember, as you know, Thomas test is done for fixed flexion deformity of the hip, to know about fixed flexion deformity of the hip. Suppose in this case, this particular case, the left hip is affected. Left hip is affected. So you you flex the opposite side hip. You flex until the flexion deformity disappears, or until your increased lumbar lordosis disappears. Okay, so you can flex it more. Okay, you can flex it more and touch the abdomen also. So there you are exaggerating it. Okay, until it disappears. How will you know that it has disappeared? That this hip will go up. So you passively extend that hip. Passively extend the hip till the lumbar lordosis is just appearing. Okay, remember this point. So how much you will flex, you don't know that how much flexion deformity. So you try to flex till it just disappears. And in the opposite leg, when you passively extend, your just lumbar lordosis just appearing. That is the amount of fixed flexion deformity. So you measure it with respect to the horizontal, that this much amount of flexion deformity is present. For example, in this child, you don't have to flex it completely. It is 50-60 degree also flexion can obliterate the deformity. Okay. Sometimes, this is confused in examination. When you ask the patient drags the leg on the bed to cause this flexion. So this is not an active movement, remember. Okay, how much active movement is possible? This is a passive movement because he is taking the help of the bed to drag the leg. So this is a passive movement on the passive flexion of the hip joint. When both hips are affected, then you do alternately Thomas test. Do this side first, then do the other side first. Okay, that is one way of doing it. Or else you can take the patient, especially if the child, to the edge of the bed. Okay, make it prone. Then passively you try to extend the hip. There you will get to know. But in adults, it is difficult to do. So in adults, we do this way to see if there is both sides hips are affected. When one is flexion deformity, then how will you assess? You take the patient to the edge of the bed. So flexion deformity gets corrected. So then you do the Thomas test by taking the patient to the edge of the bed. Here you do a Thomas test. So you see that how much flexion deformity is present. Okay. These are the questions we are asked. Sometimes, knee pain may not be there. Knee flexion deformity may be secondary to the hip deformity. No, for a long time, patient is keeping hip in flexion. Gradually there is secondary deformity of the knee. In those cases, you just examine the knee and tell that there is no tenderness around the knee, but knee there is a flexion. Probably it is a secondary deformity due to the chronic bedridden conditions of the patient. Next, extension. You make the patient lie down on the prone on the couch, immobilize the pelvis in one hand, and see that by extending the hip with the other hand. Okay, that is the amount of extension. And as you know that when there's a fixed flexion deformity, you have to tell that extension is 0. Never ever comment about opposite movement is present. Fixed abduction deformity, adduction is 0. Okay. Next we come to coronal plane deformities. That fixed adduction deformity, how to square the pelvis. Here, you get cut sometimes. So when suppose in this right side is affected, right side adduction deformity. So you have to adduct further to bring down the anterosuperior iliac spine. Okay. So you have to adduct further to bring down the anterosuperior iliac spine so that both the anterosuperior iliac spine are at the same level. That means pelvis is squared. Okay. Suppose in the patient, so right side adduction deformity, so you adduct it further and then your pelvis is squared. Similar to flexion deformity, how to know that you are not doing more? So you slightly abduct. See that the pelvis is moving. Okay. The moment the pelvis starts moving, that is the exact amount of adduction deformity. Okay. Don't exaggerate because there may be further adduction possible. Okay. It's a fixed adduction deformity. Further adduction may be possible. So you will tend to adduct further. So that will give you more deformity. So you adduct further, see that both the anterosuperior iliac spine at the same level, then try to abduct a little and see that the pelvis starts moving. That is the point you measure. That is the amount of adduction deformity. How will you measure? This is the long axis of the body. With respect to long axis body, how much adduction is there? You can measure that. Or how much adduction you did it from the neutral position. Similarly, for fixed abduction deformity, okay, the anterosuperior iliac spine remains lower, okay, in compared to the opposite side. So you have to further abduct in order to bring both the anterosuperior iliac spine at the same level. Okay, you have to bring it further abduct in order to being at the same level. Okay, you may do more also because there may be further abduction may be possible. So what you do after abducting, when you see that both the anterosuperior iliac spine at the same level, you try to adduct a little. Okay, when you see that by adduction the pelvis starts moving, that is the amount of abduction deformity. Correct? You are clear about this? Same flexion deformity, abduction, adduction deformity. So always inspect from the top of both the intersuperior iliac spine. Otherwise, there may be parallax error. Suppose you are standing at the leg end of the bed and you are doing all this abduction, adduction. It is better to see that on the top from the anterosuperior iliac spine so that you avoid parallax error and see that both the anterosuperior iliac spines are at the same level. Now, next question is asked, how will you measure the fixed coronal plane deformity without moving the hip? Then the question of Kothary's angle comes in. Okay, Kothary's angle goes by the name of Professor Manu Kothari, who was a ex-anatomy professor of this institute. Remember that sometimes people don't know him. So from his name, this Kothary's angle is there. How will you measure the coronal deformity without moving the hip? So draw the midline, join both the anterosuperior iliac spine. From the affected side anterosuperior iliac spine, draw a perpendicular to the midline of the body. So this much angle is the, your adduction or abduction deformity. So without moving the hip. Sometimes hip is very painful, arthritic hip. So how will you do the movement? You tell join both the knees and move both the lower limbs together in order to square the pelvis. Okay. Sometimes these are tricky questions which examiner asks. So it's very painfully patient not allowing. So join both the limbs. So other limb acts as a support. Then you square the pelvis. So other hip normal movements are there. So you can square the pelvis accordingly. One important point which I have learned from Professor Mohan Desai. When there is a wind-swept deformity, one side fixed abduction, one side fixed adduction deformity, you cannot square the pelvis. Remember. Okay, if you are doing well, then Mohanji will ask you last question. Suppose there is fixed abduction deformity and fixed adduction deformity on one side, then how will you square the pelvis? Pelvis cannot be squared. Remember. Huh? Next, you come to the transverse plane deformities, internal rotation and external rotational deformity. So remember, second toe is the axis of the foot. So you measure from the vertical point or vertical axis, measure how far the second toe is deviated, and you put your goniometer accordingly. Okay, second toe is the axis. So this much amount of internal rotation, and also in a flexed hip, suppose you are able to flex the hip, then you can measure the internal rotation in a flexed hip also. Okay, so that important points. Then external rotation. This is the vertical axis. Again, second toe is the axis. So you see how much is deviating outside. That is the amount of external rotation. And in a flexed hip also, then you can see the amount of external rotation. Two important points is that rotations are slightly more in knee flexed position because the ligament of Bigelow is relaxed in that position. In extension, it is slightly less. Rotations can be measured accurately in prone position by keeping the hip in extension. Usually in children, we do that. In Perthes disease or those kind of children, we do measure the rotations in a prone position. Next, about rotation, there are two important things which are asked. One is sectoral sign, one is axis deviation. Many of you will get this avian cases, one side avian affection. So when the hip is flexed to 90-degree, limb goes into external rotation. That is known as a sectoral sign. That is because the anterior superior part of the head of the femur usually gets affected. And when you flex it, that becomes painful. So limb goes into external rotation in order to protect that. That is known as sectoral sign, which is an important point finding in favor of avascular necrosis. One is axis deviation, which happens in slipped capital femoral epiphysis, that on full flexion of the hip and knee, the limb is directed to the ipsilateral shoulder. Normally, it is directed to the opposite shoulder, but if he goes into ipsilateral shoulder, then probably this is a point or axis deviation is in favor of slipped capital femoral epiphysis. Remember, rotations also can be checked while the patient in prone position, as I told you earlier. Sometimes there might be exaggerated range of movement. Okay, don't get confused. These are the conditions where you get exaggerated range of movement. This happens usually in these conditions. Suppose there is excision of the hip. Okay, you get in the history and some surgery has been done. You are seeing the greater trochanter has gone up like anything, maybe 2 inches, 3 inches compared to the opposite side. And you examine, all the movements are exaggerated. Okay, so excision hip. First, next thing is childhood septic arthritis, Tom Smith arthritis, where the head and neck is totally observed. Okay, so there is no head only. So greater trochanter is free. In those kind of patients, you will get a exaggerated range of movement in every direction. Dysplastic hips. Sometimes some movements in dysplastic hips are also exaggerated. You may get exaggerated flexion, you may get exaggerated adduction. Okay, maybe abduction is restricted, but adduction you may be exaggerated. Post-polio residual palsy where muscle weakness is there. And typically in slipped capital femoral epiphysis, the exaggerated in certain directions and restricted in the other direction. So exaggerated in extension, adduction and external rotation, and restricted in limited flexion, abduction and internal rotation. So if you see that is a differential movement, somewhere it is exaggerated, somewhere it is restricted, there is a possibility of slipped capital, femoral epiphysis if the age and other history also matches there. Next, we come to the measurements and the special tests. Okay, so measurements, first thing is the muscle wasting. Okay, first locate the joint line. First locate the joint line. Then from the joint line, you take about that 6 inches or 15 centimeter or whatever. Why do you take 6 inches or 15 centimeter? Ideally, there is no fixed landmark like that. Or ideally, where there is a bulk of the muscles are more, there you should examine. Okay, bulk of the muscle is more because wasting will be apparent there. But 6 inches and 15 centimeter, all these things, why it has been taken? Because the vastus medialis is a bulkier muscle, and phylogenetically, vastus medialis, it disappears first. If there is a wasting, first vastus medialis gets wasted compared to vastus lateralis or intermedius. That's why, slightest amount of wasting is likely to see in vastus medialis. That's why just 6 inches above the joint line you take the wasting measurement. So this is remember, this is a explanation which you can give in the examination. That's why whenever you palpate your synovium, thickened synovium, their palpate, however the synovium is thickened or not, you palpate on the upper part of the medial condyle of the tibia, medial condyle of the femur. Okay, there the vastus medialis is little deficient, so there you can palpate just below the skin. You can palpate the thickened synovium. So you measure the girth and compare to the opposite side. It is ideal that you can make a mark there so that you have measured on the normal side as well as the opposite side. Next comes the important thing about apparent length and true length, where people get confused. During the apparent length, both the limbs has to be parallel in line with the trunk, position of the limb. And it is measured between the fixed point like Giffey-sternum to the medial tip of the medial malleolus, or manubrium sterni to the medial malleolus. Don't take umbilicus because umbilicus is a variable landmark. Take a bony landmark in order to measure the apparent length. Whereas true length, first the pelvis should be squared. And I have told you how to square the pelvis. First the pelvis should be squared. Both the limbs should be in identical position. If there is this much of a abduction deformity, then that much of a abduction also you have to keep the opposite hip. Adduction, same amount of adduction. Remember, if there is a knee has a flexion deformity, you have to keep equal amount of flexion in the opposite normal knee also. Okay, so accordingly, the limb has to be in identical position. And measurement is from the anterosuperior iliac spine to the medial malleolus. Now comes the two most important slides. Just remember. Okay. So there are two things. One is apparent length, one is a true length. Okay. True lengthening is rare. Hardly you get a case where true lengthening is rare. For example, old unreduced anterior dislocation of the hip. This kind of cases, there will be true lengthening. Okay. So you don't get hardly any true lengthening. So most of the time it is a true shortening which is there. Okay. You will measure, you will find that there is a true shortening. And there is apparent lengthening and apparent shortening. So these are the three measurements which you have to play around. So if your apparent length is equal to true length, that means there is no deformity, no coronal plane deformity. Okay, no abduction or adduction deformity. If there is a apparent lengthening, then there is a abduction deformity. Apparent lengthening means difference between the apparent length is more than the difference between the true length. Clear? But if there is a apparent shortening, okay, apparent shortening, most of the time it is adduction deformity, but there is a possibility of abduction deformity. Okay, there is a possibility of abduction deformity. And remember, every 10 degrees of deformity, there is 1 centimeter. That roughly it should correspond. And never ever trail about 5 degrees or 5-degree deformity. There is a 25-degree of flexion, never ever trail, because naked eye cannot appreciate 5 degrees. 10 degree, in terms of 10 degree, 20 degree, 30 degree, always tell. Never ever tell about 5 degrees. And roughly 1 centimeter corresponds to the 10 degrees of deformity. This slide, you can take a picture of this slide, all of you. Okay, this is important. And you should remember, whenever you are in the washroom, also in the toilet sitting, you must remember this thing and just mug it up or whatever. Okay. So adduction deformity, the true shortening gets exaggerated by the deformity. Clear? Whatever amount of true shortening, it gets exaggerated. So in adduction deformity, always 100% of time you will get apparent shortening is more than the true shortening. Apparent shortening 4 centimeter, true shortening 2 centimeter. So there is a 2 centimeter of difference. So apparent shortening is more through 2 centimeter. So there is 20 degree of adduction deformity. Okay, that you can calculate. But problem is in the abduction deformity. What happens in abduction deformity? First, the true shortening gets compensated by the deformity. Then the limb lengthens. Okay. After compensating, suppose 20 degree of 2 centimeter of shortening. So while abduction deformity, first this 2 centimeter will get compensated, then there will be lengthening. So here the apparent shortening is less than the true shortening. But there is a possibility that apparent lengthening will be more than the true shortening. Okay. How this will happen? When there is a more of abduction deformity. Now, sometimes in the examination, I asked how much maximum abduction, shortening, lengthening, how much maximum deformity can occur. See, maximum deformity can occur in how much abduction is present, 40 degree. So 40 degree abduction deformity may be present. But it can happen more also when there is a destruction of the head. Okay, when there is a destruction of the head, maximum head size is how much? You have seen, you have done all, bipolar, Austin Moore, and you have seen. Maximum head size is 5 centimeter, 51, 52, 53. Not beyond that. You don't find a 60 size head. Okay. So maximum 5 centimeter. It varies from 3 to 5 centimeter. So your measurement, all these things should be within this centimeter. Unless there is an excision arthroplasty, head has gone up, you may get a shortening of maybe 3 inches or something like that. But usually the measurements are within this range, remember. Okay. So abduction deformity, true shortening gets exaggerated or gets compensated by the deformity, and hence the apparent shortening is less than the true shortening, and there is a possibility apparent lengthening will be more than the true shortening. Okay, this you remember when you do couple of cases, you will get to know about this. Next comes the Brand's triangle. Remember, before Brand's triangle, pelvis should be squared. Okay, that is prerequisite for Brand's triangle, and you know all these lines that how to draw anterosuperior spine, greater trochanter, join that. Then you draw a line perpendicular to the floor from the anterosuperior spine and measure this distance from the greater trochanter to this line. Okay. Both the lower limbs should be in identical position. That means if the knee flexion deformity is there, that much amount of flexion deformity also to be given. And it is not much of help in bilateral pathologies. Only unilateral pathology, Brand's triangle will help you. Nelaton's line, you have to see that join the anterosuperior spine and ischial tuberosity and see the greater trochanter. It remains either at the line or remains below. Okay. So many books have given 30 degree, many books has given 90 degree. All these things has been given in the books. Remember, it's an arc of movements. So whatever you do, 90 degree, 30 degree, 40 degree, so it will remain at that level. It is not going to alter. So it's an arc of movement, so it is not going to alter. So don't worry about about how much movement you are supposed to do. But at 90 degrees, it is easier to palpate the greater trochanter. So ideally, if it is 90 degree, it is possible better to do in 90 degree. But remember, on the opposite side also, at that same amount of movement, you have to do it and compare it. Next becomes Shoemaker's line. Shoemaker's line, when it is helpful, when there are bilateral pathologies. Bilateral pathology, you draw Shoemaker's line and your Chinese line, all those things. So Shoemaker's line, normally they meet, you join the greater trochanter and the anterosuperior spine and extend this line on both sides. Normally these lines meet at or above the level of the umbilicus. If they meet at a midline below the umbilicus, that means both sides it has gone up. If one side is deviates, that means that side has gone up, or opposite side, that you play around, you know that how to interpret it. Unilateral upward migration, lines will meet at opposite side below the umbilicus. Okay. Next we come to, I am not talking about those Chinese line and all those things, that we can discuss whenever you are presenting the cases. Next we come to the special tests. So special tests are Trendelenburg telescoping, Galeazzi, Ottolani-Barlow's, and Faber and Faddy test. Remember, the Trendelenburg test is done to know about the intactness of abductor mechanism. Okay, what is Trendelenburg test? Trendelenburg test is a test, clinical test done to know about intactness of the abductor mechanism. What are the abductor mechanism? The force is the abductor muscle, the lever arm is the trochanter and the neck of the femur, and fulcrum is the hip joint. Okay. And whatever affection of this mechanism, then Trendelenburg test will be positive. So what happens when the patient raises this leg, then this side the abductors contract and they pull the pelvis this way, and this side of pelvis goes out. That is the normal. Iliac crest of raised leg remains elevated in relation to the contralateral size. Whereas positive Trendelenburg test is that either it remains same level or it droops down. That is a positive Trendelenburg test. And so either the same level or it droops. That is because this side of abductor mechanism is not good. Okay, these abductors are weak, so it is not contracting, so it is drooping down. This is what is known as compensated Trendelenburg test. Sometimes patient tries to stand on one leg and tilt like that. So patient tilts the upper trunk significantly to maintain the upright posture, which is due to compensated mechanism to help the patient maintain his balance. So this is not a true Trendelenburg positive or negative. So this is a compensated Trendelenburg test. You must remember when you should not perform the Trendelenburg test, that in coronal plane deformities, whenever there is a fixed abduction or adduction deformities, you cannot perform the Trendelenburg test. Flexion deformity more than 30 degrees, patient is unable to stand unsupported for 30 seconds. Okay. In that case, sometimes we perform assisted Trendelenburg test. The examiner stands in front of the patient, holds the patient, puts the hand on the examiner's hand, and then patient stands like that. Then you see that how much weight he is putting on which hand. From that you judge that which side the hip is affected. So that assisted or modified Trendelenburg test. Next, any painful hip, ankylosed hip, or children less than 5 years. So these are the Trendelenburg should not be performed in these type of conditions. Next comes the telescoping test. So telescoping test, you must do flexing the hip and knee to 90 degree. Put your finger there as a tip of greater trochanter and give push and pull. Okay, give force in a push and pull force, and we see that greater trochanter is migrating. Okay, upwards or not. Sometimes you are not able to flex the hip. Sometimes the examiner tells also in 30 to 40 degree flexion also, you give a couple of movements, you are able to then see the telescoping test. While doing telescoping test, remember the patient's leg should rest on your forearm. Okay. And you must be holding the lower part of the thigh in order to do the test. Okay, lower part. So you must pull the femur, not that you pull the leg. You have to pull the thigh. Okay, rest the leg on your forearm. Next, Lees or Galeazzi test. This is done to know whether shortening of the femur or shortening of the tibia. From the front, you see shortening of the tibia. From the side, you see shortening of the femur. Ottolani and Barlow's test, these are done in children in order to know about dysplastic hip or dislocation of the hip. Here people get confused about what is Ottolani, what is Barlow. And normally what we tell, Barlow means Baharlo. Okay, that means you dislocate the hip. Ottolani means underlani. You are relocating the hip. Underlani, Ottolani, Barlow's test. So you do adduction and give push so that hip comes out. Here you give abduction so that hip comes in. Okay, Ottolani and Barlow's test. Next comes Faber's test, and Faber's test is flexion, abduction, and external rotation. Okay, so remember this test is positive if the knee remains above the opposite leg or straight leg. Then this test is positive. Usually it is positive in iliopsoas spasm or SI joint affection or dysfunction of the SI joint. Whereas Fadder's test, flexion, adduction, and internal rotation is done to know about piriformis test, or piriformis syndrome also gives rise to pain. And sometimes, impingement, femoroacetabular impingement we test, this Fadder's test. Last remains the, gait of the patient. Gait is separate lecture altogether. So either you can tell the gait from the beginning of your examination, or you can tell at the end of the examination. But it's a common practice, better you tell in the end of the examination, because gait is always difficult to answer, difficult for the students. So when the examiner has asked you all the questions, when you are finished all this towards the end, you can tell the gait. Otherwise, if you start in the beginning, then they will start you asking about the gait cycle and all these things. Okay, so better that you start at the end, patient's gait. So do not forget the examination of the hip. Examination is incomplete without the examination of the spine, SI joint, and the knees. So always examine the SI joints and the knees and the spine also. Sometimes it is asked, how will you test the SI joints without moving the hip joints? So you tell compression distraction test or Genslin's test, where you take the patient to the edge of the table and extend by holding the pelvis, you extend the hip joint. There you can get pain. And poor rectal examination in case of protrusio. You never do poor rectal examination during the examination, of course. But if you are suspecting protrusio, then you can tell the examiner, at least when they ask that I'll do a poor rectal examination. Sometimes it is asked. So finally, what you do? Finally, you give a clinical diagnosis. Okay. Finally, you give a clinical diagnosis. So your examination findings should pertain to tell you whether it is a synovitis or a arthritis, whether it is an unstable hip, whether it is a coxavara, or is a protrusio or ankylosis. Your diagnosis should fall into one of these. Okay, one of these. And it may be due to what? Due to tuberculosis, due to avascular necrosis, due to Perthes disease or dysplasia, whatever. So your clinical diagnosis fall into, your findings should pertain to one of these conditions, remember. Okay, so this is your clinical diagnosis, then the etiological diagnosis. Then you can discuss about the etiological diagnosis, what is the cause, what is the points in favor, points against, etc. So I conclude, take home message, take a careful history taking. History gives you 50% diagnosis. You can suspect and accordingly proceed to the examination. People don't listen to the history, listen the history carefully. Little bit, you give time, at least 2-3 minutes you give time, to let the patient tell his story. Meticulous examination in order, what I have told you. Basic tests are Thomas test, squaring of the pelvis, apparent length, true length. Okay, these are you must be extremely thorough in this. Otherwise, you may likely to get caught during the examination. Special tests like Trendelenburg and telescoping test. Then associated spine and SI joint tests also you do and mention in your findings. And finally, you give a summary with a provisional diagnosis. Okay. I thank Dr. Ajinkya for helping me in preparing this presentation, and thank you all for a patient listening. Any questions, or we can go for the cases and we can discuss during case discussion also.
We can have 1 or 2 questions if anyone want to ask regarding hip examination.
Sir, in this chronic dislocated hip, mainly in posterior dislocation or something, there will be formation of a false acetabulum. So in that cases, how can we say an instability? Because the telescopic sign sometimes will be negative.
Say, you cannot tell instability, but it might be a stiff hip or it might be an unstable hip.
Sir,
when that is dislocated,
yes, sir.
So it might be a stiff hip.
Yes.
Because over the period there is no movement.
Yes.
So you present it like a stiff hip. Or you tell it's an unstable hip, exaggerated movements will be there. So that's a clinical diagnosis. You are not giving etiological diagnosis. Etiological diagnosis you can then discuss. Due to this, It's a steep hip due to chronically dislocated hip. But it might be because there's a history of injury, blah, 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 flexion, adduction, internal rotation, deformity, like that.
One more.
Sir, and in avian hip, in early cases, there will be differential rotation. Because it is an early disease, so the cartilage is maintained. So the anterolateral head is involved. So is the differential rotation because of the painful protective muscle spasm mechanism, or because of the cartilage?
See, any disease, first stage is synovitis. Okay, be it septic, be it tuberculosis, be it avian, there will be synovitis. So usually those cases are not given in the examination. Synovitis, you can tell clinically it is synovitis because extremes of movements are restricted. But there won't be any differential rotation. If there is differential rotation, then it is specific to the avascular necrosis. Okay, if it is going into external rotation and flexing. Otherwise, if it is synovitis, then tunnel movements are restricted, you tell it's synovitis. But those cases are usually patients are given when it is arthritic stage, when examination finding.
Sir, if we are getting a secondary osteoarthritis case, in which case we are getting a proper positive history of alcohol or a steroid in the history given by the patient, then can we say in the provisional history, provisional diagnosis that the patient is a case of secondary osteoarthritis secondary to vascular necrosis? Most likely etiology being
most
alcohol.
likely it may be due to your clinical diagnosis is osteoarthritis, secondary arthritis.
But can we say
arthritis of the hip? Clinical diagnosis, I told you, synovitis, arthritis of the hip.
Yes.
So since there's a history of avascular necrosis, history of steroid intake, blah blah, all these things, maybe it may be due to avascular necrosis.
Sir, my doubt was, can we say avascular necrosis as it is a X-ray finding, which
we are telling you,
okay,
we are not confirming the
Confirming
diagnosis.
the
We are giving a provisional diagnosis. Most likely etiology. Okay, most
we
likely
can-
etiology. Tuberculosis of the hip. Can you confirm on the clinically? You are clinically you are telling arthritis.
Okay.
Most likely due to tuberculosis.
Yes. Thank you so much.
So there are a couple of questions on Zoom as well.
Yeah.
So one of the questions is, why should the Trendelenburg test shouldn't be performed in flexion deformity of more than 30 degrees?
Because the patient cannot stand on one leg on that side. When there is a 30-degree flexion deformity, how the patient will stand on one leg? It is difficult to patient to stand.
Okay. And there's another question. What other aspects do we need to mention in a case of protrusio apart from PR examination?
No, protrusio, there will be, flexion will be full almost. There will be differential of movements. Rotations will be restricted completely. Internal rotation, external rotation will be restricted. Whereas flexion movement will be full, almost 100, 120 degree flexion will get. So uniaxial movements. Abduction, adduction depends how much protrusio is there. Initially, there may be some abduction possible, but when it is a severe protrusio, grade 3, suppose protrusio, then abduction, adduction also gets restricted. Yeah. Morris's bistochondric test, when you press, I didn't tell those things in detail because I know then it would have gone another. So Morris bistochondric test you can do in those cases.
And one more question there. How does the clinical examination in a bilateral hip case differ from a unilateral hip case? Just a few points which will help
No,
the
I-
students.
I think we'll cover it up.
We'll cover
Yeah.
that up in the examination. I have told bilateral flexion deformity how to check. Bilateral abduction, adduction deformity. You cannot do the square the pelvis like that. We have told. So we'll discuss.
No, we can take that question during the discussion.